Okay, so I think a lot of agreement there. So let's move forward to the next topic. And so in the frontline setting, a lot of discussions here at ASH about this. And so I've divided it up into the transplant and the non-transplant. So if we take the transplant setting first, there were a number of presentations at this year's ASH. The SWOG trial, which I actually presented, and then there is the IFM trial, the outcomes of the IFM trial. Interesting study from Philippe Moreau comparing VTD with VCD, follow-up on the Spanish study with VMP with Revdex, and also interesting data comparing Kyprolis with Velcade. So a number of different things to think about in the frontline setting. So if we take them one at a time, this was the SWOG study that I presented early on Saturday morning. And I'd just like to point out, this is a comparison of Velcade, Revlimid, and Dex using the 3-week schedule. And so to compare that with the Revlimid and Dex, the two drugs, we used the 1-month protocol. So this is a 28-day cycle, 6 of those, so 6 months. And 8 cycles of the 3-week. And this allowed us to conserve the drug exposure. And you'll also notice here the dexamethasone here, 2 days, 20 milligrams here, 40 milligrams, the 1 day a week, the low dose. So a lot of effort went into this particular part, stratification for intent to transplant. And so another important part of this, there was no upfront transplant, but patients were stratified with a later intent to transplant. And all the patients went on to lenalidomide plus dexamethasone. Again, discussion about do you need to use both of those, but in this case, both, and in an open-ended fashion until progression to toxicity or withdrawal. And I think you guys saw the PFS data with 43 versus 30 months, about a 1-year difference. And then the overall survival with a median follow-up of 55 months. I think that this is one of the few phase 3 studies where we actually have a tangible overall survival number to compare, and with, again, about a 1-year difference in the overall survival. So I think this was a regimen that started in 2008, shortly after Paul described the use of the VRD. And so then, coming back to the IFM Dana-Farber study, which has been the focus of a lot of comment and discussion here this year at ASH, we have obviously the left-hand side here, the RVD with autologous stem cell transplant. Over here, RVD, mobilization, more RVD, and the option for SCT at relapse. So basically one thing that's been discussed a little bit more this meeting is that it's actually an early versus late part of the comparison here, incorporating transplant. And again, as we've seen already, it does integrate calibrization, the MRD assessment, and we've already seen a little bit of that. And so MRD, early versus late transplant, and so very interesting. And so this early look at the French side of this study caught a lot of attention, and this was presented on Sunday. And this is the PFS data with clearly a statistically improvement benefit for the transplant arm. But a lot of discussion as to whether this will translate into a survival benefit. Michelle did show a little bit about that, and there's a trend towards, in the non-transplant arm, there may be more progressions related to disease and deaths, versus the other arm where there's less. But much too early to call, I think, and people are really waiting for the Dana-Farber part of this trial to see what is going to happen here. A lot of interest in the VTD versus VCD, an induction study to see if VGPR would be increased. This was the endpoint, and a lot of interest in the fact that the VTD won out with a higher level of VGPR versus VCD. So this really tips the balance towards a Velcade or a proteasome inhibitor IMID combination as a choice. Interest in the follow-up of the carfilzomib versus Velcade with a benefit for carfilzomib over Velcade. So this was quite an interesting study. Wee Ju Chung from Singapore was actually not able to present this. It was presented by Dr. Demopoulos. And then the Torino data of 1 day a week carfilzomib. Obviously a lot of interest in possibly using carfilzomib, but 1 day a week would be fantastic. And so very, very interesting to see the very robust responses with improvement over time using the 1 day a week Velcade in the 1 day a week carfilzomib combined with the Cydoxin and the DEC. So I think pretty robust follow-up on that. And so now what we have in the frontline options, you know, we have the various combinations with actually the carfilzomib seeming to win out a little bit in terms of depth of response. And this was something that was discussed at the satellite session on Friday as to whether or not these data would be sufficient, particularly in the high-risk setting, to actually recommend KRD over VRD or VTD. And so a lot to think about now. So perhaps, Paul, you might be the first person to take a stab at this one. So what is the best frontline choice today in the pre-transplant type setting? And an addendum to that would be is, if you're thinking about it, would it be different related to high or standard risk?
Yeah, it's great questions, Brian. I think, first of all, congratulations on your SWOG trial. Very important to validate that, you know, RVD versus RD, clearly not only a PFS difference, but also a survival benefit. And I think that was huge, very, very important. I think that the data that struck me from that study were, number one, the PFS benefit was substantial. Yes. You know, we were looking at over a year. Yes. And at the same time, you also saw a substantial survival benefit. And that was, I think, tremendous testimony to the efficacy of the approach of integrating a proteasome inhibitor with an IMID, but at the same time, the maturity of that information and that trial. One of the caveats, of course, is that it was intravenous bortezomib, as you said so nicely in your talk, and that obviously is something we would look at differently now with subcutaneous administration to reduce neurotoxicity. But apart from the neurotoxicity, the combination was well tolerated. And I think so as we think about this, we have to also be aware of current randomized trials that are ongoing. And the most important one, I think, is Shaji Kumar's from the ECOG group, in which he's comparing RVD to KRD. And I think there are a couple of points to bring out. First of all, the ECOG trial has been on clinical hold twice, I believe, for updates in some of the toxicities that emerged that was surprising. And they were actually on the KRD arm. So I think we have to be very careful about this, because at the end of the day, the trial's ongoing, it's enrolling, but I think until we have randomized data, we need to be very careful about assuming that one regimen is better than the other a priori with cross-trial comparisons. Having said that, I'm very impressed that, you know, KRD is very active and it drives deep responses that are clearly very durable, and I think Andre's work has been particularly important in this regard. So I think we need to know a little bit more about what's coming up front before we can sort of say it's KRD now based upon this data versus RVD, recognizing the Endeavour data you showed in the relapse setting for the doublet. I think at the same time, I think clinicians have choices. But I do think we need to know a lot more before we can sort of broadly recommend one regimen versus the other. Okay. And I think that's reasonable. The transplant issue is so important, and obviously it's been a privilege to work with our French partners in this regard. What I think is important to share with our audience is there was no survival difference, Arm A versus Arm B. That was critical. In fact, Arm A was 83%, and Arm B was 80%. And the difference in the number of myeloma deaths was, if you looked at the actual numbers, quite small. And the reason I say that is because on the transplant arm, there were actually 11% of the deaths encountered were due to second primaries of AML type. Now, it's a very small number, but that's relevant to just bear in mind. So I think as we think about, you know, this survival signal, we're starting to see the real importance of choices, and not only that, the real importance of allowing these data to mature before we make decisions. And I think the important message from the IFM-DFCI collaborative effort is that not only that, but the French trial had 1 year of maintenance which stopped. In the US trial, we continue maintenance until progression, learning from our own experience with CLGB 100, 104, and Antonio's beautiful work, which shows that maintenance until progression matters, something you validated as well in your study.
Right.
So I think, you know, we just have to be careful. And I think in all of these settings, recognize these are early reads in absolute sense. Right. Clearly, transplant has a role. That's, I think, the clear message from Michelle's work. But remember the median progression-free survival, what was it? It was about 8 to 9 months.
Right.
So you gain 8 to 9 months from a transplant. Well, remember, with maintenance until progression, in the CLGB 100 and 104 trial, we gained 2.5 years.
Right.
So I think we have to think about that in context before we make immediate assumptions.
So the answers are not in.
I think that's fair.
I can see that. So what would you say in answer to this question then? So VRD, I'm hearing.
I think your trial is the highest level of evidence, and I think Vincent really nailed that today at the session this evening with the FDA, and his Mayo guideline, which obviously Joseph is part of, is that RVD is now the regimen up front, and I think KRD is very exciting, and don't misunderstand me. I think it's great promise, but I think we have to be a little careful because we're in this. You know, we're looking for our patients for the long term now. The survivals are improving, they're really mattering. So even a small amount of early toxicity we have to approach with a little caution.
Be cautious. Yeah. Okay, so Antonio?
Well, I can certainly echo what has been just said by Paul, and I would say that today the first message is the free drug combo is a standard of care.
I agree.
And today we do have, and I would partially disagree with the French study. We do have 2 standards. One is certainly VRD, and has been clearly shown to be superior by the SWOG study. And the other one, and I'm not so sure, is VTD, could be VCD.
Yes.
Because in the French study, the difference in response is 10%, not that much, without difference in progression-free survival.
Yes. These patients moved on to a different protocol.
You know, we should be cautious in saying that one combination is superior to the other just on a 10% difference in response rate. So generally speaking, I would say free drug, VRD or VCD are the major standard of care available. Completely agree, transplant is still a standard for younger patients. I would also make another comment that probably around transplant we do need to deliver 4 cycles of induction and 2 cycles of consolidations. So we cannot just give 3 cycles of induction transplant, that's it.
No, you need the consolidation piece.
We do need to increase the induction and the consolidation to around a number of 6 cycles. And I completely agree with Paul once again that the maintenance gave a 2 years advantage in terms of progression-free survival. And today the transplant is giving 1 year. So the real standard should be considered free drug approach, 6 courses around transplantation, and a maintenance approach.
So, Joe, what do you think about this?
Yeah,
I know that you're the Cybor D king.
No, well, I'm not sure I'm the king of anything, but
I didn't want to be against him, so I opened to the VC.
Yes, okay.
Antonio's showing me the love today, that's for sure. But, well, no, I mean, it's hard to disagree with what's been said. I mean, I think that the power of the proteasome inhibitor and the IMiD together is being validated, no question.
Fair. Good
I do think in certain contexts, VCD can still be considered.
Yes.
You know, in our MSMART guidelines that we've just revised, I mean, we've essentially put VRD as the standard of care in at least standard risk patients and intermediate risk patients with a translocation 414. In the highest risk patients, we still struggle with that. And that's why we've put in that we would consider giving KRD because of our experience with it. Now, just pick up on one thing that Paul said that I think is so important is that whether it's this discussion right now or even when we get to the relapse discussion, we're in a marvelous situation where we have more options than almost we know how to sequence, number one. Number two, patients with myeloma are living longer than ever before. So the sequence will ultimately matter.
I agree.
And introducing something that can cause significant toxicity up front that may be a permanent phenomenon is critical.
Yes.
So ensuring that we're trying to minimize neurotoxicity, as we've said, by
really
giving
important,
bortezomib subcutaneously and weekly, generally speaking.
Right.
Maybe a few exceptions to that for cycle 1 or 2 in certain contexts. I think that's very important. And I understand what Paul was saying about some of the concerns about carfilzomib up front. On the other hand, the lack of neurotoxicity there has been of value to us. We're going to be very interested, for example, I know we're about to move to the transplant ineligible group, but of using perhaps a combination like ixazomib, lenalidomide, dex.
Absolutely.
Up front would be very attractive. If I can preserve my patients from having significant neurotoxicity, neurotoxicity, or literally any toxicity, knowing that this is not a short race anymore, this is a very long race, I think really factors into the decision making. But in summary, I think as you've said already, and your work was fantastic, obviously, Brian, that VRD is in many respects the standard. VCD can be considered and KRD can be considered.
Yes. And my only comment additionally from participating in Andre's trial with KRD is please be careful about thromboembolism. Okay. Because we've clearly seen an increase in the rate of thromboembolism with KRD. In the ASPIRE trial, it was actually 3-fold higher for KRD thromboprophylaxis. And in the upfront setting, we saw the same thing, where basically we had rates between 15 and 20% in the study, and that was on aspirin. And I think, therefore, we need to be very careful about how because obviously low molecular weight heparin may be prudent. Because to your point, Joe, I couldn't agree with you more about neurotoxicity. That can be an absolute bear in the long term. Right. Similarly, though, substantial thromboembolic complications can also be
that's
a real
very
issue.
serious.
So we have to be smart about that as well. Yeah.
So just before we have to move on, but last thing for you, Antonio. So the VTD data are actually quite good. So I mean, if Revlimid is not available, that's a reasonable backup choice, right?
Certainly yes, although to some extent I would be cautioned because with VTD the risk of peripheral neuropathy is not trivial.
So still you would be thinking maybe VCD?
Yeah, well, I honestly, it's difficult to make a clear definition, but certainly today the PFS of VTD and VCD is equal.
Right. Yeah. Okay.
So from that point of view, VCD is better tolerated with a similar PFS rate and a 10% difference in response.
And especially if you're anticipating longer use of it instead of the typical 4 cycles. Exactly. If you're pushing it to 6 and 8 now, I'm getting a little bit more nervous about that much thalidomide. If we get beyond 4 cycles,
that's an excellent
I, as a provider, get anticipatory neuropathy.
All right, so VCD is not dead.
No, I would say that the two major, honestly, I'm in favor that the two major standards are VRD from one side and VCD from the other side. And certainly there is mainly a cost issue over there. If there is not a cost constraint, VRD is number one and the alternative is VCD. That's, I think, is
very good. Okay. So let's move to the non-transplant setting. And again, we have some interesting choices here. We have the data that we've seen for some time. Obviously, the VISTA trial, the VMP long-term follow-up, sustained benefit. So obviously a very good regimen. And then obviously more recently, we have the LENDEX, the first trial, showing that the two-drug combo RevDex better than MPT, but with some nuances to that we've become familiar with now related to continuous therapy. And looking at the different cutoffs, the initial cutoff and then the more recent cutoff showing that the continuous RD is superior in terms of the PFS versus the other two regimens with short-term therapy, and that this is sustained in terms of a survival benefit for the continuous arm. And so we have the two aspects there, the RD and the continuous therapy aspect. And now we have a lot of things to be thinking about. We have the MP-based approaches. Are we okay with carfilzomib maybe as an additional possibility? What do we think about adding in daratumumab with VMP, for example? You know, there's some interesting ideas there. And for the RD-based approach, now we have several options to be thinking about. The new drugs, ixazomib, elotuzumab, we'll talk about, and the daratumumab, really open up a lot of things to be considering. This is sort of the current standard of care published by the French, looking at the eligible patients and the non-eligible patients for transplant. But really, what do you think about recommendations for non-transplant patients? So Antonio, you've published a lot of papers on this. What do you think right now is the standard in this setting?
Well, the comment to some extent could be easy. As we were discussing in the younger patient, VRD and VCD with transplant, you take out the transplant and you get the same
answer.
Because basically,
and we're done.
Okay, that was easy.
Because basically, once again, free drug combination is a standard. Proteasome inhibitors plus IMiDs, or if cost is an issue, alkylating agent are the two options. Now we have a history of melphalan, but probably in the future more and more melphalan will be substituted by cyclophosphamide. So at the end of the day, the message is free drug, proteasome plus IMiD from one side, proteasome inhibitor plus cyclophosphamide on the other side. The recommendation is a number of cycles of induction that should be around 9, follow once again, if feasible, by continuous therapy that is, as usual, adding another 18 months of remission duration. I think this could be considered the standard. I would also add that when you have frail condition, comorbidities, probably a two-drug combination could be considered the treatment of choice, and you might eventually consolidate it after an induction with 2 courses, move into a free drug combination.
Yeah, so obviously,
that to some extent could be considered an easy approach. The same of the younger patient, just take out the transplant.
Right. And obviously the aspect of being frail or not frail and the comorbidities that you've drawn attention to the last couple of years. I mean, I think we've now taken that on board as something that we always need to be thinking about. So Joe, do you agree with
I agree.
this?
I think one of the beauties of your trial was that it included individuals over the age of 65 as well. So, I mean, I would just, the 2 maybe points I'd enhance from what you said, Antonio. One was that frailty really has to be considered. So do I believe that every single transplant ineligible patient tomorrow must have a 3-drug combination? Perhaps not. I mean, there may be some. I mean, the evidence of just RD from the first study is quite impressive. As long as we're treating them for a longer period of time and being able to control their disease. But I agree. I mean, our MSMART guidelines now are such that individuals would get VRD and then step down to RD after a period of time of induction, like you've said, about 9 to 12 months. Point 2, Brian, is, and I don't want to be the death nail to it, but I cannot imagine starting a patient ineligible for transplant tomorrow on an MP regimen anymore.
No.
Up front.
No,
in light of what we said earlier, people living longer, the melphalan has that risk of burning out the marrow a little bit more.
Yes.
I think we're deferring melphalan. Not that it isn't a great drug and potentially can be used later, but I don't. In your 2 boxes there, I would focus on the RD-like combinations with a proteasome inhibitor and other, as opposed to going to the MP. With time, who knows? As we use the monoclonal antibodies, I think that will be a great opportunity in the future as well, which may mitigate a bit of what we've said.
Right, and so Paul, you actually have worked on the RVD light, which would fit right into this discussion.
No, it's a very. Thank you for saying that. I mean, it's been led by my colleagues at Mass General and my colleague Jacob Laubach. So what we've had is work led by Andy Yee and Elizabeth O'Donnell, and Jacob's been led our site. And what we've basically done is looked at RVD light, which is subcutaneous bortezomib weekly, low doses of Revlimid, excellent tolerability, superb response rates, and really no surprises. You know, low rates of vascular toxicity, neuropathies very manageable with sub-Q and weekly, building off Antonio's work. So RVD Light has worked very well. I have to say, I think that I agree entirely with both Joe's earlier comments and Antonio's, that in the older population we tend to not think of it in the same way anymore. 3 drugs, probably almost certainly better than 2 usually, with the exception, as Joe pointed out, that RD can be very active in the frailer patient and very useful. So I think I completely agree. I think that as we go forward, this older population is going to be benefiting from drugs like Activism coming earlier.
Absolutely.
Right.
And I think that
the all-oral approach, possibly.
The all-oral approach, and I think the other thing that to me is very interesting is where the antibodies will sit.
Right.
Particularly elotuzumab in the older population, and for that matter, you know, remains to be seen where Dara will belong, but I think Dara has great promise as well.
So that's actually exactly where we're headed right now. So this feeds right into the next discussion, which is linked to these recent approvals, and so.